Hi there, welcome back. So I'll be talking still about problems in metabolic bone diseases. So we've talked about osteoporosis. Remember, our problem in osteoporosis is the increase in osteoclastic activity in relation to that of your osteoblastic activity. The next topic is osteomalacia. Now, in osteomalacia, this is defined as the loss of bone related to vitamin D deficiency that would result to marked deformity of the weight-bearing bone and pathologic fracture. So the main problem in osteomalacia is vitamin D deficiency that would lead to decrease of calcium, leading to signs and symptoms that are almost the same as your osteoporosis. Next, it would cause softening of your bone caused by the inadequate deposits of calcium and phosphorus. And then this is the adult equivalent of your rickets or vitamin D deficiency in children. Now, what are the possible causes of your osteomalacia? One is your vitamin D disturbance. Vitamin D disturbance is related to inadequate production because this is the most important factor in the development of our osteomalacia. Next, the lack of sunlight exposure. So your sunlight exposure is supposed to activate your vitamin D. And then dietary deficiency, which would be supposedly it's necessary for bone formation. However, if your patient is not having vitamin D intake, then it would not be helpful to our calcium. And then another could be the abnormal metabolism of your vitamin D. So take note that vitamin D has a function to maintain calcium and phosphate for normal bone mineralization. It is considered to be inactive once it is absorbed in our intestines. But by the time it would travel to the liver class, it would be converted to calcidiol. And by the time that it would travel to the kidney and vitamin D, it would be activated by the sunlight, it would become your calcitriol. So you would notice that the medications given as vitamin D supplement will be your calcitriol. Now, drug therapy. This drug therapy causes adverse effect that can result to osteomalacia. One is your phenytoin. Phenytoin is an anti-seizure drug. Then you also have your fluorides, and then you also have your barbiturates. So your diazepam, lorazepams, long-term use of this medication could lead to your osteomalacia. Other than that, your patient who would have liver disease would also be at risk for osteomalacia. Why? Recall that ADEK are fat-soluble vitamins, primarily processed and activated through the liver. And recall again what I've mentioned, that it is your liver that would convert the inactive vitamin D to calcidiol. How about renal disease? So chronic kidney disease can interfere with the synthesis of calcitriol, okay, with the most active vitamin metabolite. So in renal disease, recall that your kidney will convert calcidiol to calcitriol. So meaning damage to the kidney will prevent this conversion. Next, inadequate absorption. So if your patient had after gastrectomy, just like after your Bilirth 1-2, after your bypass surgery, after your bariatric surgery, after your or your patient would have malabsorption syndrome, there will be a problem on the absorption of calcium. Okay, for your patients who have undergone surgery, there is a decrease in the surface area of the intestine that is able to absorb your calcium. Whereas in malabsorption syndrome, okay, there is really a problem on absorption due to the hyperactivity of your stomach. Then you have your inflammatory bowel diseases. So your Crohn's disease, for example. Okay, recall your ulcerative colitis and your Crohn's disease, which are inflammatory bowel disorders. So if our patients' class would have the inflammatory bowel disorders, they are unable to absorb the nutrients that are coming through their intestines. Then for the kidney diseases, okay, so you have your CKD, okay, acute tubular disorders, okay, what I mean by tube there is your renal tubules. Then you have your metabolic acidosis, and then you also have your hypophosphatemia. So the tendency in hypophosphatemia is that there will be a calcium will be compensating or will be reacting to the decrease of phosphate, so calcium will be going out of the bone, okay, aggravating the disease process. Then other risk factors. So there are less affluent nations and countries where famine is common, so lack of calcium, old adults, remember, poor calcium absorption, adherence to a very restrictive vegan diet without supply of vitamin D, poor intake, of course, homelessness, and then drug or alcohol abuse, which also impairs absorption of calcium. And then the poor and marginalized will be also at risk. Now, let's talk about the pathophysiology of your osteomalacia. So, liver and kidney diseases. Again, liver because of ADEK, fat metabolism. Kidney diseases, failure of conversion of calcidiol to calcitriol. This would lead to decrease in activated vitamin D or decrease in calcitriol. Other than that, your GI diseases. So GI diseases could be your inflammatory bowel diseases, could be your surgery, celiac disease, CBDO is common bile duct obstruction. So common bile duct obstruction would lead to problems on metabolism of fats because your bile duct or your bile, could metabolize the fats. Then your pancreatitis, okay, which would lead also to the damage of your pancreas, which is vital also for fat metabolism, and then your small bowel resection. Okay, your GI diseases here could lead to decreased fat absorption. Decreased fat absorption is also leading to decrease in activated vitamin D. All of these factors combined, they would lead to failed calcium absorption. Because there is a failure of calcium absorption, the effect on the bone will be twofold. One, there will be inadequate bone mineralization. Okay, not enough calcium in the blood, not enough calcium from the nutrients, there will be no calcium going towards your bone. The next problem is, since there is lack of calcium in the body, your body would try to compensate. And who would be that hormone that will try to compensate for the decrease of your calcium? That will be your parathyroid hormone. And because of the increase of your parathyroid hormone will cause bone breakdown. Would tell the bone, hey, bone, release some calcium. Okay, and with that, that would lead to bone mineralization. Okay, bone demineralization, So there is inadequate bone mineralization or bone demineralization. So what happens to bone? Bone would become soft and weak. Okay, and then the skeleton would again soften and weaken. So what are the effects to the patient? The patient may have kyphosis. Your patient may have bowing of legs and then the waddling gait. Then, if the risk for fall will continue, the pathologic fracture of your radius and femur will be evident. So, what are the management for this patient? Calcitriol, your activated vitamin D. Even if I will give lots of calcium for this patient, without the vitamin D, the calcium will just be useless. And then daily sunlight exposure, please. Okay, your daily sunlight exposure will ensure that the vitamin D taken by your patient through the diet will be activated. Next, on X-ray. Okay, the X-ray would show demineralization of your bone and then would also show your compression fracture. Now, for the laboratories would show decrease of calcium and phosphorus. So there is an overall decrease of serum calcium. Okay, by the time class that your PTH will try to compensate, there will be a slight increase in the calcium levels. But later on, since the bone will also not have a source of calcium, okay, it will decrease in the disease process. So this is how a bone of a patient with osteomalacia would look like. So notice that there is a lesser mass compared to that of the healthy bone. So what are the assessment findings for this patient? There will be muscle weakness. There is waddling and unsteady gait. The waddling and unsteady gait would lead to falls later on and subsequent fractures. Okay, so class, look at this. The muscle weakness is actually the reason for the waddling and unsteady gait. Okay, the muscle weakness is brought about by your hypocalcemia. Okay, recall that your hypocalcemia will manifest with signs and symptoms of tetany. Okay, you would have your muscle cramping. Okay, so recall your Vostek sign and then your Trousseau sign. Your patient would have bone pain. The bone pain tends to be aggravated by the activity and worse at night. And then there will be skeletal malalignment, such as the bowing of your legs, okay, the long bone bowing, or spinal deformity, which is similar to that seen in osteoporosis. Okay, so other than the bone tenderness, skeletal misalignment or malalignment, the untreated osteomalacia will have the risk factor of, or the big risk of having fractures. So the victims, vertebra, rib, and long bone. Okay, still the usual site for your fracture, just like your osteoporosis. So what are our laboratory tests for this patient? Serum calcium. Serum calcium may be normal until severe or late stage of the disease. How is it becoming normal? Again, because of the increase of your PTH, and because of the increase of your PTH, okay, the bone is being demineralized. So the body will try to compensate. Okay, so that's why early in the disease, the serum calcium may still be normal, or the serum calcium may be actually decreased once it is severe or late. Now, for the serum PTH, your PTH would be increased. It's a compensatory mechanism because of the decrease of your serum calcium. Okay, so class, I hope that you can remember that when I'm saying serum, I'm talking here about the availability of a certain substance in the plasma, in the bloodstream. Okay, so class, once there is a decrease of calcium, again, I would like to say that once there is a decrease of calcium, there will be an increase in your parathyroid hormone. And this increase will not be helpful to our bone. Next, you have your serum phosphorus, which may also be decreased or normal. Then you have your alkaline phosphatase. Class, the alkaline phosphatase is decreased in malnutrition and increase in clients with liver or biliary tract dysfunction. Okay, so your alkaline phosphatase could be able to differentiate whether the problem is malnutrition or there could be a possible liver or biliary tract dysfunction. Added to that, the X-ray of the bone would reveal a decrease in the cancellous bone and the lack of osteoid sharpness. So as shown earlier, there is a decrease in the density of the bone. The bone biopsy may be actually needed to confirm the diagnosis because it is the bone biopsy which will be able to identify whether what cell is increasing in activity. Then you have your DEXA, your dual X-ray absorptiometry. So it's the most common screening tool, diagnostic tool for measuring the bone mineral density. Okay, so it will be just like your osteoporosis. So what is our medical management for this patient? Take note, main problem is the decrease of vitamin D. So we give vitamin D. The minimum RDA for vitamin D, RDA is recommended daily allowance, it's 400. For older adults, it's 800. Okay, if not, increase vitamin D through diet. Milk, eggs, chicken, liver. You have your cereals and bread products which are enriched. Then sun exposure, and then drug supplement. Okay, so class, again, to help the patient or to prevent or treat osteomalacia, we need this diet therapy for our patients. Then you can have the following nursing diagnosis. One, altered nutrition less than body requirements. The second would be the risk for injury. Then you will have your impaired physical mobility and knowledge deficit. That will be the end of your discussion in osteomalacia. So I hope that you will recall osteoporosis, osteoclastic activity is higher compared to your osteoblastic activity. Whereas in your osteomalacia, the main problem is that there is a decrease of your vitamin D leading towards the decrease of your calcium levels. Now, let's talk about your Paget's disease. Class, Paget's disease is also known as your osteitis deformans. It's a progressive, the word is progressive metabolic skeletal disorder. It is a result from a localized excessive metabolic activity in the bone with excessive bone resorption and excessive bone formation. Okay, take note, there is excessive bone resorption. Recall, resorption is destruction, but there is excessive bone formation. Let's see what's happening. Okay, so Paget's disease. Your Paget's disease class, osteitis deformans, is common among those aged 50 years old and above. Okay, it is more common among males and common among those with family history. And there is a slide that explains that this is idiopathic. Okay, a known cause. In your Paget's disease class, there is a proliferation of osteoclasts. There is an increase in osteoclastic activity, hence the increase in bone breakdown. Okay, there will be an increase in bone resorption. Okay, when I say bone resorption, again, this is bone destruction. And because of this increased class in bone resorption, the difference in the pathophysiology of your osteoporosis and Paget's disease is that in Paget's disease, there is an increase in osteoblastic activity. We did not hear of this in your osteoporosis. Okay, so there is an increase of osteoblastic activity in your osteitis deformans. This increase in osteoblastic activity is in an attempt to compensate with the increase in your osteoclastic activity. Compensatory. Or later on, it would result to localized rapid bone turnover. Okay, so what would be the result? It would have the classic mosaic disorganized bone pattern. Okay, classic mosaic disorganized bone pattern, which is a classic sign of your Paget's disease. Pathognomonic to Paget's disease. Now, what will we do for this patient? We will have pathologic fracture still for this patient. Skull, femur, tibia, pelvis, vertebrae. The face tends to be triangular in appearance because of the cranial enlargement. There will be impaired hearing. Why? Okay, your patient would have the thickening of your otosclerosis. Okay, your patients would have the thickening, of your ossicles leading towards otosclerosis. The spine is bent forward and rigid. The shin has a tendency to rest on the chest. And then the thorax would become immobile to have respiratory problems related to this. And then there will be tenderness and warmth, and then pain, which is deep and aching. The pain, which is deep and aching, is actually related to the thickening of your bone. And then the laboratory would reveal an increase of your ALP, okay, and then an increase of your hydroxyproline. Okay, hydroxyproline. So, if your patient is manifesting with pain, we have your NSAIDs. Once your patient is at risk class for pathologic fractures, you have your walking aids and then your physical therapy. Then, biphosphonates. Biphosphonates are given for this patient. Then we have your plicamycin or mithrasin, which is a cytotoxic antibiotic, okay, which is shown to have some benefit on your Paget's disease. Okay, so class, look at this. Okay, there is thickening of the bone, and the thickening of the bone again is because of the increase of osteoclast, but the osteoblast is trying to help. But the help of the osteoblast would just result to the thickening or abnormal growth of your bone. If you would read into your supplementary material, it would say that the normal laminar bone would be replaced by haphazard disorganized bone. The word there is haphazard disorganized. The bone would not be structurally sound. That's why it would lead to bone pain, joint pain, arthritis. Joint pain is arthritis. Then you will have deformity. Then you'll have fractures. So the complications: pathologic fractures, neurologic complications, cardiovascular diseases. This is class an X-ray of a leg bone affected by Paget's disease. So note how the bone is misshapen. This is already very curved, and then it's punch out appearance. So, complications. Fractures will be there. Neurologic complications due to nerve compression. Cardiovascular disease. So, diagnosis. Mentioned there, alkaline phosphatase will be increased. X-ray CT scan, okay, will be showing the abnormality or the bone changes. Okay, your bone scan will be showing that there is increased metabolism, and at the same time there is an increase in anabolism in the bone. So what is our medical management for this patient? Aspirin and NSAIDs for pain. Since your problem is the increase in osteoclastic activity, we go back to the drug of choice, which is also for osteoporosis, biphosphonates. Okay, your biphosphonates. Then, calcium and vitamin D supplements will be needed by your patient, okay, especially during the time of repair, okay, bone repair. Then you'll have your calcitonin. Okay, so your calcitonin could help also on your calcium levels. Then for the surgery, there will be a need to repair or realign the fracture, and then replacement of the hip and the knee. So our possible nursing diagnosis for this patient would include chronic pain and then impaired physical mobility. That will be the end of your discussion on Paget's disease. Our next topic is on arthritis. Okay, so you have your gout, your osteoarthritis, and then your rheumatoid arthritis before we proceed with musculoskeletal trauma. Once again, maraming salamat po sa pakikinig.